Well, tonight I was asked to say a little bit about coronary atherosclerosis or coronary artery disease. And one of the things that I think is important is that we kind of define what the disease is, because maybe not everybody even knows what we're talking about. So I'm simply calling it, coronary artery disease. Some people call it atherosclerosis. Some people call it hardening of the arteries. Some people call it heart disease. Some people call it heart attack. Well, they're all kind of related. But a heart attack, you'll see, is sort of an end stage of this disease, but the disease starts a lot sooner. And so the purpose of tonight, I hope, is that I can show you some things that you can do, that we can all do, to maybe prevent the disease or slow it down, or if it already exists, maybe reverse it a little bit. So with that in mind, we'll kind of go forward. Let's see. Do I have to point this anywhere special to make that? Oh, okay, it worked. Thank you. So, the coronary artery and atherosclerosis, the terms that we're talking about, every artery in our body has the same characteristics. So whether it's in the heart or whether it's in your leg, it looks the same actually under a microscope. And so this is a cartoon or an artist's rendering of what an artery looks like. But every artery has an outer layer that's called the adventitia, an inner layer that's pink here, that's muscle, and an inner layer called the intima. And any artery anywhere in the body has those three layers. If it doesn't have those three layers, it's not an artery. People mix up arteries and veins all the time, right? Arteries and veins, blue and red and all that stuff. So in your leg, and those things that the surgeons take out for bypasses, those are called veins. The blue things in your arm that you see, those are veins. They are nothing like arteries, but people mix them up all the time. Arteries have muscle in them, and they're thick. And you can't see them anywhere in your body because they're down deep, but you can feel them if you put your hands on your pulse and you feel something tapping up against you. That's an artery. The veins don't have a pulse. You can't feel any pulse in a vein. When they draw blood, they're drawing blood from a vein. Two different things. Blood from a vein. An artery would hurt if they were drawing, hurt even worse than when they draw from the vein. So, if anybody has ever been in the hospital and had an arterial puncture for a blood gas or something, you know that hurts a lot more. Anyway, that's not the subject for tonight, but I want you to understand arteries and veins are different. We're talking about arteries and atherosclerosis, the buildup of fatty plaque. So it's important we understand. Now, over one's life, sometimes a little fat or cholesterol deposits, lipid gets into that artery, and this is what the artist is drawing here, and it builds up over time. So if you put fat in the artery, fat, the Greek word for fat is athero, and the Greek word for hard is sclerosis. So atherosclerosis is hard fat. That means over the years of your life, that fatty buildup grows, and it gets harder and harder and harder. And actually it is that. Under, if you could be in the pathology lab and touch it, it's hard fat. It's kind of crispy, crunchy stuff. So you don't really want that in there. That's not a good place for it. But let's see what it really looks like. So this is an actual coronary artery sliced open, so you can look inside of it from a 50-year-old man. The reason we have this picture is because the man's no longer alive. He died as a result of a heart attack, and you'll see what happened. But this is the lumen, so it's kind of like a donut. This is the hole in the donut here, and this here is the wall of the artery. So remember I told you that all the walls have three layers in them. This one does too, but you can't quite see it on this slide. You will on the next slide. But this yellow stuff here, that's the fat. Doesn't belong there. That's atherosclerosis. This one you can see all the layers here. But at any rate, you can see there's an outer layer and an inner layer. This inner layer is the intima. Then the middle layer, somewhere over in here, has the muscle in it, and the outer layer is fibrous tissue. But somewhere subintimally, just underneath the intima, is where the fat grows. So everybody can see in this slide, this is the fatty part. This is the opening. This is about a 50% narrowing. So this will grow inside somebody, and this person, this is not the one, the first person, somebody else, but you wouldn't even know you had that. So that can grow to this size or much bigger than that even, and you wouldn't know it's there because there's plenty of room for the blood to flow down here. Everybody following me? So it's a silent disease for years and years and years, maybe 50, 60 years. You have no idea it's growing inside of you because you can't feel this, and the blood is flowing down here, and there's plenty of room for the blood to flow. So what's the problem? Why do we care? Because one day, if you get unlucky, this fatty area cracks right there. So here's where the blood was flowing, and this plaque ruptured. The minute that happens, when the plaque ruptures, then a blood clot starts to form. It's kind of like if you cut your finger, you hope that the blood doesn't keep leaking out, you know, so you form a little scab there, a little blood clot. Well, this is a bad place to cut your finger, you know. So if nature happens to be unkind to you and this vessel tears at this spot, and typically that's exactly where, this is a real specimen, that's where it tears at this end, at the edge, either up here or down here is where it tears, and we don't know why it tears, but one day if that happens, then this happens. Then the blood clot starts to form and like a jelly bean growing inside of you. Remember that opening that I said was plenty big for blood to flow? Well, when this starts happening, now it's not plenty big anymore. And that's going to grow and grow and grow. And at that point, you're going to have symptoms, emergency kind of symptoms, usually chest discomfort, some pressure, heaviness in the chest, shortness of breath, sweating, you don't feel well. And if you get to the emergency room fast enough before all this happens, or even if this happens, there's a chance that we can open it up. But nature's going to close that off. The blood clot, the clot is going to completely fill that vessel. And when it does, there'll be no blood coming out the end. It's like a drinking straw that now is clogged. You can't suck any liquid through it, no liquid could come out. That is what causes the heart attack. So before this step, there's no heart attack. The heart attack only happens if you clot off the blood vessels. Is that clear? That's why we give aspirin and tell people to take an aspirin, because aspirin helps this blood clot to break up, or actually helps it to not form in the first place. And when you come to the hospital, they give you intensive blood thinning medications to try to make the blood clot go away. But it's the blood clot that causes the heart attack. But it's the fat that led this whole process to begin in the first place. So if you can roll the hands of time back, maybe we can get rid of this. So this is the timeline. So where I showed you the blood clot is over here. This is just an artist's rendering again, but what this represents is like a blood vessel. So here's the day you're born, somewhere over here, and then here's by the time you're in your 20s and 30s and 40s and 50s. So that guy was 50, his looks like this, right? But when we're born, it looks like this, nice and clean. This is where the blood flows. Here's the fat growing. But the fat didn't grow when he was 50. It grew when he was 20 and 30 and 40, right? So it's silent. So that's like all of us in the room. You know, this thing could be growing. Doesn't have to be, but it might be. So we're going to talk about the risk factors that lead to the development of this plaque. Could we prevent it? Could we do something to minimize the growth? You know, if it didn't grow so much, maybe we wouldn't ever get the heart attack or wouldn't ever get any symptoms. So we're going to talk about it a little bit. Now, this is the tricky part here that a pathologist defined, you know, about 25 years ago now, and it's kind of complicated, but I'm not asking you to understand all this, just to understand that the normal vessel kind of looks like this. As you develop the fat, it kind of fills in there. But what happens is the blood vessel actually stretches outward so that the lumen is preserved. This is called the lumen, or the opening, like in the straw. So it takes a really long time before it gets like this. Severe here. So this could be going on for decades because our body keeps fighting it off and it stretches out and gets a little bigger, so we don't get symptoms. That's why we call this, again, the silent disease. So it could be growing. That's why these genetic markers are so important, because if you know you're at risk for some of this stuff, then we could do things today to slow it down, or to maybe even reverse it a little bit. I'll show you that. The key is that, you know, maybe some of us in this room are over here, maybe some are still here, and some might even be here. But as long as we treat it, we can fight the disease. What happens if you don't fight the disease? Well, this is the prevalence of cardiovascular disease in the United States. This is in adults starting at age 20. I started at age 20 because the disease starts well before age 20. In fact, when men and women were killed in the Korean War, the pathologists were smart enough to look at their hearts to see they didn't die of heart disease, they died of a bullet wound, but their hearts were diseased. 18-year-old men and women. And they have studied children that are in auto accidents when they're 10 years old, and they unfortunately don't make it, and they look at their hearts and they have disease at age 10. So this is not a disease of 50-year-old people, it's a disease of everybody. That's why you shouldn't feel bad, you know, if you're in this room, you're not a bad person. It's everybody's disease, you know. So look here, age 20 to 39, they already have disease, 40 to 59 have disease, but it grows a lot faster, you know, that plaque gets bigger. So by the time you're 50, 60, 70, till you're 80, you know, this is the percentage of the population that has cardiovascular disease, look, if you're over 80, you already have about a 75 or greater % chance that you have some of this disease, whether you have the genetic predisposition or not. Why do we care about the genetic? Because we want to try to catch it over here. See if we could identify people earlier, and then we have more years to work on it. Is that clear? So if you look here, this is the number of adults having heart attacks. So remember, I told you coronary disease, the previous slide, is just that you have something. But heart attack means that that donut hole closed up, that there was no blood going down for a period of time. Look, age 35 to 44, there were 30,000 men and 10,000 women. These statistics all come from the National Heart, Lung, and Blood Institute, which keeps data on all this, and the American Heart Association. And we don't have 2010 numbers for this. So this is a few years old, but up to 2004. And there were 30,000 heart attacks in men and 10,000 women in the age 35 to 44. If you're over 75, there are about 300,000 heart attacks in who? In women. Women, right? So everybody thinks this is a man's disease. Wrong. It's not. It's equal. In fact, in later years, the women have more disease than the men do. When we balance it out over a lifetime, it's equal. About 400,000 men and 400,000 women will die this year from heart disease. It's about equal. But everybody, if you took a multiple choice test, everybody would say men have the disease. No, it's equal. But it gets the women later. Gets the men earlier. So the men are the lucky ones. They die at 50. The women die at 70. But the point is, you got to die sometime. And if you are in the United States, the leading cause of death in the United States in men or women is heart disease, not cancer. I'll show you that. This is coronary heart disease, what I've been talking about. Here's strokes, here's lung cancer, here's breast cancer. Everybody fears these things, but that's not the likelihood. This is many times more fold. Now this is per 100,000 population. That means 130 deaths per 100,000 population, 31 deaths per 100,000 population. This is females with breast cancer. So this is females, right? So what does that mean? See, 30 and 130? That means there's many times more, right? Many times more deaths from heart disease than breast cancer in women. Lung cancer in men or women, many times more deaths from heart disease than lung cancer. Stroke, many times more deaths. So why do we talk about cancer? Because people are afraid of cancer, they hate cancer. But you should actually fear heart disease, kind of, because it's more likely that's going to kill you. All right. So here's the good news. That's all the bad news. The good news is the mortality trends for heart disease, because the American Heart Association has been pounding on this and getting the message out and telling people you got to eat better and you got to exercise more and you got to do good things and get your genes tested and do all whatever. And so we're getting a little bit better now. So this is, again, this purple line, or whatever color that is, magenta, is females. And remember I told you more females than males actually end up dying. It's about even. You see here about 400,000, but slightly more females than males. This is American Heart Association, National Heart, Lung, and Blood Institute statistics. So this is for 2006. There were about 430,000 deaths in females, about 390,000 deaths in males. And it's coming down. So we're actually starting to see an impact. The heart disease death rates are coming down a little bit. But they're still way above everything else, but they're coming down. So that's the good news. This is just another depiction of that same thing in 2006. You see that sort of the last 10 years or so we've been able to see a little decline through all the public health measures. All right, so now I told you all that stuff. Let's talk about the risk factors. How do we get in this place to begin with? Well, genetics plays a major role about this, and we'll let our genetics counselors talk to us more about it. But these are the commonly mentioned risk factors that you can do something about. Genetics right now is a little hard to do something about, so I'm not going to focus on that. But we can do something about hypertension or high blood pressure. Can't change our age, but you should note in all those curves that the older you are, the more likely you have heart disease. That's just a virtue of living on this planet, for a longer period of time. Diabetes, an epidemic in the United States. We'll talk about that sort of as it relates to obesity, which is another epidemic. Elevated LDL cholesterol. This is a cholesterol problem. So that yellow stuff I showed you was the waxy fatty substance called cholesterol. That's a big issue in the United States, and we'll talk about that, and we can do a lot to help that, a lot. So we're going to spend some time on that. If you have poor, GFR is glomerular filtration rate. It's a measure of kidney function. If your kidneys don't work well, that's not so good. That's actually a risk factor for cardiac disease. And then the family history of premature cardiovascular disease. So if your mother or sister had a heart attack under age 65, or your father or brother had a heart attack under age 55, then you're at family risk of cardiovascular disease because they had an event at a young age, at a relatively young age. You know, if your father was 80 years old when they had an event, it's kind of not that high a risk because they lived to 80, you know, but if they were 47, that's a huge risk. So we've got to talk about it. Microalbuminuria, again, kidneys, we'll leave that for another day. Obesity, we'll talk about that, and physical activity, and tobacco, we'll come back at the end to talk a little bit about that, because those are reversible things. So the theme is, what could we do about it, right? So we're going to look at what can we do about cholesterol, what can we do about high blood pressure, what can we do about obesity, physical inactivity, tobacco use, and how will that impact us. So let's start off with cholesterol. I picked that one first because I'm a lipidologist and I'm interested in lipids, and that's kind of been the major benefit in terms of risk reduction in the United States in particular and around the world, is that we finally figured out a way to get this cholesterol down. Happens to be through medication. Some people don't want to hear about that, but that's the way we do it. And it has saved tremendous numbers of lives. That's probably singularly responsible for that downturn in the curve. When statins came in, deaths from heart disease started to go down. So, you know, all the bad things you hear about medications or things, you should say some good to the drug companies, because if they didn't invent those products, we would be just dying more. The curves turn around just exactly when the statins come into the market. But we'll talk about that, and let's look at some of the actual data. So why cholesterol? Why do we care about your cholesterol? Believe it or not, 30, 40 years ago, we didn't, because we didn't even know. If you look back, if any of you have some blood work just laying around in a drawer somewhere from, let's say, you know, 1975, if you could find that, you're going to find your cholesterol level, and it's going to say the normal value for cholesterol is like 350 or some ridiculous number. Or, you know, now it won't say that anymore, because we didn't know. 30, 40 years ago, we didn't know that high cholesterol was really bad. They thought it was okay. Actually, up to about 360 was normal. Now, if you look at your slip, it's going to say it has to be less than 200, and I'll show you even less than that would be better. How did we learn that? From this. This is the multiple risk factor education program, or multiple risk factor intervention trial, and actually I participated in this when I was in medical school, and finally was published in the 1990s, but this took place in the 1970s and 1980s. They just followed a bunch of people. How many people? A lot of people. You can't see it on this slide, but they followed 350,000 men. Didn't follow the women, sorry about that, but you know, it was believed that heart disease was a disease of men, so they followed 350,000 men. That's huge. You know, the average study when they, in the TV news tells you they did a new study, that's in like, you know, 500 people, 1,000 people, maybe 10,000 people. This was in 350,000 people. Hard to make a mistake when you look at 350,000 people. In other words, if you can prove it in that amount of people, there must be something to this. So in the 350,000 people, men, this is what they found. If your cholesterol was at 150, that's total cholesterol, your death rates were down here. If your cholesterol was 300, you had, so that's double, 150 to 300 is double, you had 4 times increase in the rate of death. Not the rate of disease, the rate of death from heart disease. So that's when the public health measures went into place in the United States, and we started to talk to Surgeon General. Everybody started saying, hey, Americans are eating too much fat, we better do something about this, because they saw this data going back 25 years ago. And so today, now we all know that we should lower our cholesterol, but this is where we found that out from, because we didn't know. We didn't know. Now here's something very interesting. These are peoples around the world, around the planet, that have very low levels of cholesterol. So the question always comes in, like, what's the normal cholesterol? How do you know? Well, we look at populations that you know, live in primitive societies. They don't go to McDonald's or Burger King or places like that because they don't have it. In fact, they don't even have a kitchen. They don't even have a house. You know, many of them live in tents or live in, you know, outdoors, pygmies, etc., Inuit Indians, and they're hunter-gatherer humans. They're like our ancestors. They have to go out and catch their food. So they don't go to the supermarket, they go out and kill an animal and eat it, or they grow crops and they eat them. And their cholesterols are very, very low. See, the total cholesterol, that means not the LDL, we'll break that down in a minute, but the total cholesterol is down around 100, 130. And here's where most of us are, somewhere off the chart here at 220, 240, 250, average in the US about 250. So we're way over here, and the people in primitive societies are way down here. Guess what? They don't get heart attacks. You know, before we exported a lot of US business to, you know, Southeast Asia and places like that, they didn't know what a heart attack was. But then, and I'm not, you know, I'm not trying to be smart, you know, when the, you know, Western civilization kind of moved over there, and now they have, you know, Kentucky Fried Chicken and things like that, they're also getting heart disease. So that in some of these countries they didn't have a coronary care unit in their hospital because they don't treat heart disease, they treat other diseases. We treat a lot of heart disease here. So there's a message there. We can do better, and we should. All right. So how does this all happen? This is a colorful slide. I kind of like it. And it tells us a little bit about how does the cholesterol get into us? How do any of us get this cholesterol? All right, so our liver, this is the liver, a representation of the liver. Liver's inside your body on the right-hand side, up under the rib cage there. It's a pretty big organ. And the liver is an amazing organ. It's an absolutely fantastic organ, does amazing things. And one of the things the liver does is it makes cholesterol. So I just said cholesterol was bad. No, actually I didn't. Cholesterol is necessary for life. We need cholesterol. We just don't need too much cholesterol. That's the problem. So the liver makes just the right amount of cholesterol for most of us. But then we do this. We take stuff in our diet. We eat. So this represents what we take in from the diet. So the liver makes some, and then we put some extras in there. And then it all goes and gets mixed up in our intestines, and then we absorb it. There's all receptors for that. And the cholesterol, their fat, the yellow stuff comes in as chylomicrons, they're called. They're little packets of fat that come into our intestines. And then they get into the bloodstream through the lymphatic system. Some of this is a little technical, and if you're not sure what I'm saying, it sort of doesn't matter. Just understand that we absorb the fat, it gets into the bloodstream. Okay, and then what does it do? Then it ends up, some of it comes back out, some of it goes back to the liver, and it all kind of cycles around. So our body is in homeostasis, means it regulates the cholesterol. A lot of this is under genetic control. But some of it is under dietary control. Turns out our liver makes about 900 milligrams of cholesterol a day. In the US, we take in at least 300 milligrams a day. That's 1,200 milligrams. And then we put out in the stools about 1,200 milligrams. So 1,200 in, 1,200 out. Everybody's happy, except we're regulated at a very high cholesterol level. What if we didn't take in 300 or 400 milligrams of cholesterol? What if we only took in, 50 milligrams of cholesterol like the Indians do, the tribal Indians I'm talking about? Then we would continue to produce from the liver, but we wouldn't take in as much here, so we would have a net negative balance of cholesterol. So that's how you lower your cholesterol. Take less in here. We can't tell our liver to make less, or can we? Well, there is a way. We can take a statin medicine. That's the pill the doctor can give you that tells the liver that, hey, don't make so much cholesterol. So you take in less with your diet, your liver makes less, and we downregulate everything and the cholesterol level falls. So those are ways that we can lower cholesterol. Now, what if you do that? If you lower your cholesterol, do good things happen or bad things happen? Well, we didn't know. So we had to test it and prove it. So this is another older study. But this study here is a conglomeration of many different studies. Off on the right here are a lot of the statin trials, cholesterol-lowering medicine trials. And over here, these are non-statin trials. These are, well, one of them is for us. But these are studies that were done with older agents, resin-binding agents, bypass surgery. They used to do an operation to bypass a part of your intestine so you couldn't absorb fat. That actually worked. There was this POSH study. It's on here somewhere, down here. Partial ileal bypass. And so however you lowered your cholesterol, whether you did it through surgery or you just closed your mouth and didn't eat all that stuff, or you took a pill, however you did that, they constructed this curve and they showed that this is the LDL cholesterol. As it comes down, MI and death rates come down. So if you lower the cholesterol, something good happens. However you lower it, diet, exercise, pills, whatever, it gets better. So Dr. Grundy from University of Texas constructed this graph a few years ago, and this is part of our National Cholesterol Education Program. And this is a graph that shows that as you bring your LDL stands for low-density lipoprotein, that's the so-called bad cholesterol. There's good and bad. There's HDL is the good, LDL is the bad, this is the bad. If you forget which way it goes, L, think lousy. So this is the lousy cholesterol. So your LDL, and my LDL should be low. We should try to bring it down. So the average is way up here, but if you bring it down, this 40, that's where it is when we're born. If you take a baby that's born today, their LDL will be about 40 to 50 in their cord blood. That's what we're born with. And then we mess it all up, we make it go up and up and up to 160. But the Indians that I showed you, the pygmies, they don't mess it up as much, so they stay right around 40, 50, 60, 70 throughout life. A total cholesterol of 130 means the LDL's down here. So Grundy showed that if we could bring our LDL down close to where we were born, that good things will happen. The risk for cardiovascular disease gets lower. So as a result, our government, trying to help all of us, put all these don't memorize any of this, but there's all these guidelines that go back to 1988. Remember I told you when we first started to understand that this was a problem was in the 80s, because the studies were done in the 70s when I was in medical school in the 80s. So 70s and 80s. So by 88, the government said, you know, we better issue a report to all Americans that we better do something about it. So that was in 88. That's the first Adult Treatment Panel 1 report. In 1993, they issued a second report. Dean Ornish, if any of you remember him, had some studies and others that said, gee, we got to lower it even more. And then in 2001, we had an update that said we should lower it even more. And then in 2004, there was another update based on these studies that said even more. And then in 2006 was the last update, said, you know, we really should strive to get the LDL cholesterol down around, if possible, 70. Where's the 70? You're born at about 40, 50, 60, so they said get it less than 70 if you can. Who should get it less than 70? People at risk. So if you're at risk for the disease, you should get it down. Not everybody's at risk. Not everybody genetically is at risk. You know, if your mom and dad, you know, lived to be 95, both of them, not one of them, but both of them, and they didn't have heart disease, and nobody in your family has had heart disease, you may not be at risk. But many of those in this room and many out in the world do have some risk factors. So we would want to bring yours lower. So at least, in my opinion, below 100 if you have some risk factors, and maybe down as low as 70 if you're at high risk because you're a diabetic or because you already have the disease. Now, so anyway, that's what we're recommending, but how do you get there? What are we going to do? So for the next few minutes, I want to talk a little bit about how can I help you to get where you want to be. So let's say you decide you want to do something about this. You should talk to your doctor, obviously. Diet and lifestyle are the most important things. But you know what? I'll show you some data near the end that diet and lifestyle, although extremely important, are kind of hard for Americans to follow. I don't know why exactly, but we just don't do very well with that. So even though your doctor tells you to do something and you want to do that something, at the end of a few weeks, are you still doing that something? And most people aren't. So every study has shown that people can sustain things for a few weeks, maybe up to 3 months, up even to 6 months, but beyond that, it all goes back to where it was before. So you lost weight, but then you gained it again. You brought your cholesterol down, but you gained it again. So I'm reminded of a patient I saw a few years ago who didn't want to take any medicines. So I said, that's fine with me. Then you got to go on a strict diet and a strict regimen, and we gave him all that information, and he did it. And he came back about 2 months later, and he actually normalized his blood sugar, normalized his cholesterol, normalized his blood pressure on no pills. So I know it can be done. Then he came back 6 months later and said, Doc, can you give me some pills because I can't follow the diet and the lifestyle anymore. That was a defeat. That was sad, but that's the truth. That's what happened. So then he wanted the pills all of a sudden because he knows he couldn't do it. So for those of you who can do it through diet and lifestyle, do it. That's number one. Every doctor will tell you, do the diet and lifestyle. But if you're not doing that, then don't kid yourself. Then you better talk to your doctor and be honest and say, hey, you know what? I'm really not doing what you want me to do, so maybe you should help me some other way. So this is only for those of you that flunked that part of it. You know, so if you can do it that way, then you don't need all these pills. But this is the class I want to talk to about. These are called the statins. Everybody heard of statins? You hear them on TV, you hear them all over the place. And the statins they have names. These are some of them, and I don't preach about brands, but I show the brand names for you so that you'll know what we're talking about, so you can see the brand names here. These are the generic names that I prefer to call them by. But why do I start with these? Because these are the most potent agents we have to lower cholesterol. And when these came on the market, cholesterol rates started to drop in the United States and heart disease started to go down a little bit. I showed you that curve earlier. So that's why we like these pills, because they have done some very positive things for us. But before them, there were other agents here, and some of you may remember older agents. These are some of the names. Questran is an old one that was like a powder you had to mix up in water. If you were treated 25 years ago, your doctor had to use that because these weren't around. And then there's some other things, niacin, very important, and some other things, fiber. And we can talk about it, but let me go through this. So why the statins? Why do we preach preach about statins because this is the rate-limiting step in the biochemistry of cholesterol. As the liver makes cholesterol, it has to go through this step. I'm not going to teach you the biochemistry. I just want to show you that this is an enzyme here that allows the formation of cholesterol. The statins block this enzyme. That's why they're powerful, because the liver can't make as much cholesterol. If you take that pill, it blocks here, and this can't go on to make cholesterol. It still makes some. Your body makes cholesterol all the time. But it'll make less, so it's really had a major impact. And these are all the studies. I'm not going to go through tonight. These are all the studies, each one of these, going back to '94. Most recent major study was Jupiter in 2008. These are all many thousand patient studies on statins to show the benefits of statins. The reason I go through this is because a lot of my patients don't want to take these medicines. So I tell them, don't take it. But you should go and read before you make that decision, because in all these studies, including the very first one, the people that took the statins lived longer. So when you don't take the medicine, that's fine. But you have to know the consequences of that. So, it's important that you discuss it with your physicians. All these studies show. Now, I'll show you some of the data, because I thought it was worth showing. So this is the first one, 1994, the 4S trial, Scandinavian simvastatin survival study. This is the results of that study. It was 4,444 patients in 5 Scandinavian countries that had high cholesterol levels and evidence of heart disease, and they put them on the statin that was available at that time, which was simvastatin. And this is the result. This is a very interesting result. You have to look carefully at it. So this is the group that got the placebo. This is the group that got either 20 or 40 milligrams of simvastatin, and there was less what? Mortality means death, right? So not they felt better, they looked better, their pictures in the cath lab looked better. No. It's who lived and who died. That's the ultimate study, isn't it? We only really care who lives and dies. You don't really care what your cath lab picture looks like or your stress test. Did you live or die? So that was the first study in 1994. The reason I'm like flabbergasted why I'd say this is because I have patients today that still say, I don't know if I should take these medicines. They're bad for me. Well, how is it that in 4,444 patients you lived longer if you took it than if you didn't take it? So anyway, you can go back and read that if you want. It's in the British journal Lancet in 1994. But every study after that showed the same things. Here's another one. This is US, North America. No, I'm sorry. This is in Scotland. Those of you from Scotland, this is in Scotland. In men, different medicine, not Simva, but Prava, the same thing, less deaths. And this is a kind of a summary of all these different studies. CARE here was cholesterol and recurrent events trial. That was a US trial, showed the same thing. A lot of these have been done in Europe. It's easier to do these studies in Europe. Heart protection was 20,000 patients in Great Britain. They brought their cholesterol levels down to an LDL well below 100 here, and they had the lowest event rate. So that's why the doctors talk about this stuff, because we're trying to help people to live longer. Okay. So reversal trial, this was a cool trial. This was done in the United States by Steve Nissen from the Cleveland Clinic. And this was a study of patients with coronary disease. So you had to have the disease to get in. It was a cath lab study. They had to put catheters inside of you and prove that you had coronary disease. And then they gave them 40 milligrams of one statin versus 80 milligrams of another statin. Forget about which one. The thing to note here is that this is a powerful dose of a powerful statin. This is a medium dose of a weaker statin. So as a result, this brought the LDL cholesterol lower than this did. Everybody follow me? So these patients, they're the same kind of patients, but these took a more powerful drug, these took a less powerful drug, and the plaque volume in the cath lab got smaller. And the plaque volume in the cath lab here got bigger. So we call that trial the reversal trial, because for the first time we showed that actually if you treat aggressively, you can make the disease shrink a little bit. It turns out that this was repeated later on with another medicine, a different medicine, and it worked with that medicine too. So if you bring the LDL low enough, you can actually shrink the disease a little. Not much, a little, but a little is great. There was a question in the back.
Is it your opinion that even if you have a normal level of cholesterol, that you take the statins in any case?
Well, again, as a physician, we don't want to over-treat anything, but what we call normal a lot of times isn't really normal anyway, based on some of the data I showed you. So I think it depends on your risk profile, and we can talk more specifically about individual risk. But what I'm saying is there doesn't appear to be a harm to the statins, even if your cholesterol is low. In the heart protection study that I showed you, that was 20,000 patients in Great Britain. About 4,000 of those 20,000 patients had an LDL cholesterol less than 100 before they went on the statin. but they went on the statin anyway, and they all benefited. So that's like your question. What happens if your cholesterol is low and you take it? Nothing. It does good for you too.
And other negative factors?
Well, all medicines have side effects, and these medicines certainly have their share of side effects. So that's why if you really have no business taking the medicine, you might want to talk with your doctor.
You're not going to talk about the...
I can. It depends how much time. I can go on for hours. But let me take this question, then we'll do the side effects maybe at the end. Okay.
At the level where there was reversal, do you know what the LDL level?
Yeah, it's right here. This is what it ended up. It was 79. Yeah, and this group. Both of these groups were higher than this at the beginning, and it brought it down to 110 and down to 79. It was after this study that the guidelines called to bring it lower, a little bit lower. You remember I told you the guidelines.
What would the level be if you were 62?
What do you mean if you were 60?
If you had an LDL of 60.
Oh, that actually, I even have that, but I don't think I have this slide. In one of the studies that came after this study using rosuvastatin, a different statin, they actually achieved exactly that. They achieved an LDL of 62, and those patients had reversal. They had reversal in that study. So, in fact, in that study where it was 62, they did actually a little bit better than these patients, because what I didn't show you, and you can read the article I gave you, the reference, this is Journal of the American Medical Association, but this 0.4% decrease and 2.7% increase, it's only 500 patients, it's not 10,000 patients. So actually the statistical difference between those two did not meet, it was not statistically significant, but in the next study, the one you're talking about where they brought it to 62, there was a statistically significant benefit. So the answer is 62 is good, that's a good number. That's a good number. And we'll come back to side effects or whatever. Anyway, this is the most recent, it was the Jupiter study. This is another interesting study, because to get into this study, to answer that gentleman who's got paged out his question, LDL had to be less than 130 to get into this study. So this was a low cholesterol study, not super high, but people with risk, maybe genetic risk, et cetera. And so you had to have a low LDL, but a high C-reactive protein, which is a marker of inflammation. If their marker of inflammation was high, but their cholesterol was low, then they got randomized to a medicine called rosuvastatin, 20 milligrams versus placebo. Look, 8,000 patients, 8,900. So these are big studies. This was published, this is the original, the publication came out just in 2008, November of 2008, in the New England Journal of Medicine. But here, what happened is, as this gentleman's question, what happens if you bring your LDL down? They reduced their LDL in this study from, it had to be below 130 to start. They brought it down to about 50 something, right? And you'll see the HDL stayed good, the C-reactive protein went down, triglycerides went down, and their mortality, here, this is cumulative incidence of MI, stroke, unstable angina, revascularization, and death fell by 44%, the group that got the rosuvastatin. So again, speaking to what I'm telling you is if you're that person where you're at risk, this is a way to lower your risk. The theme tonight is how can I help you, not how can I not help you. So this is one way that you could be helped possibly. If you're in that group, you're going to do better if you take the medicine. All right, so we proved this relationship. We talked about that. Now, what about when should you start this therapy? What's the story with that? So I'm sort of embarrassed to tell you that as an adult cardiologist, we lagged way behind. It's the pediatricians who said, you guys are missing the boat here. We got to be treating these people young. So I'll bet you your pediatrician didn't tell you that for your children or you or your parents, right? But now these are the guidelines in the Journal of Pediatrics, the American Academy of Pediatrics guidelines. These are the official guidelines that your pediatrician or your grandchild's pediatrician reads, and it says if you have a bad family history of coronary disease, you should be getting a blood test between ages 2 and 10. So little babies get blood tested. And everybody by age 10 should have their blood tested. If you're overweight or obese or you have high triglycerides or low HDL, then you better start doing something about it when you're age 2 to 10. And if you're over the age of 8 and your LDL is real high, 190, or above 160 but a bad family history, or you have some risk factors even as a youngster, then they say pharmacologic intervention should be considered. So they're saying treat the kids age 10. So now your pediatricians are actually treating the children at age 10. You know why? Because it takes 30, 40 years to develop the disease. If you start at age 10, you're going to prevent the disease when the person's 40. If you start at age 40, it's a little late. If you start at 60, it's a little late. Never too late, but you understand my point. So that's the pediatricians. All right, let's talk about some of the other risk factors. So let's talk about hypertension. Hypertension is very common in the United States, so we should talk about it. Why are we still talking about it? Because we're doing a horrible job treating it. That's why. Because question?
Can I just ask a question
Sure.
about cholesterol before you move on?
Yeah.
If you have really high HDL cholesterol, can that ever be a problem if it's too high?
Too high HDL is not a problem. In fact, if it's above 60, if the HDL, so HDL is the good cholesterol, if it's above 60, according to our national guidelines, you could subtract one risk factor, and that is like a good thing. I'll tell you that be careful with that one, because there's some newer data that will be emerging, we're not going to talk about tonight, that it has more to do with your HDL functionality than the actual number. So some people have a low HDL, but it's very functional HDL, might actually be okay. And some people with a high HDL may not be as protected as they think they are. But in general, high HDL is good. So if your HDL is above 60, that's a very good thing. You should be very happy about that. Although that doesn't prevent absolutely cardiovascular disease. You can still have disease with an HDL above 60, but you're less likely to. So that's good. Let's just talk about the blood pressure for a minute, and I'll try to go through this maybe faster. So the point of this slide is just to tell us that this is the blood pressure patients not meeting their goal graphically. This is, again, national data. And so we're not meeting our goal, and the goal is 140/90, which most cardiologists would say is way high anyway, right? Your doctor probably wants it lower than that, but this is how many people in the United States hit a 140/90 or below. Horrible. So if you look here at the increasing cardiovascular risk, this is where you want to be, 115/75. If you're over here, 135/85, you already have twice the risk of somebody else. If you're here, you have 4 times the risk, and if you're here, you have 8 times the risk. Okay, this is data, and here are the publications. You'll get the things to read about. So why am I saying that? It's because we already know we're letting people get by. And people talk themselves out of treatment all the time. People come to the office, and what do they say? I don't know if any of you are like these patients, but see if this rings a bell. They come to the office and I measure their blood pressure, it's 150/90. I say, my high pressure was perfect yesterday. When my other doctor checked it, it was perfect. I don't know why it's so high today. I was rushing, I was late for the appointment. Then the next visit, it's 150/90 again. My family doctor never gets that. They always get one. So, in other words, they talk themselves out of being treated. What I say to people is, that's fine by me. I'm just your doctor. I'm not your brother or your relative. That's up to you. But bear in mind, okay, you just cheated yourself, because you now have 4 times the risk of somebody else who has their blood pressure treated. So when you go to your doctor and they think you should treat your blood pressure better, don't talk them out of it, because you just talked yourself out of this. I mean, seriously, you have to be careful. Now, there are people who once in a while their blood pressure did zoom up that one time, so of course we take it. But, not every time, and it can't be an excuse for everything. So people never want to take medicines, and I'm a human being, I understand that. But you might be talking yourself out of a good thing. Just be careful. All right, so why do we care? Because if your blood pressure is above 140/90, you have 69% chance of first heart attacks occurred in people whose blood pressure was above. 74% of cases of strokes. Look at this, first strokes had high blood pressure. 91% cases of heart failure. So you're damaging your brain, you're damaging your heart, you're damaging your kidneys. Deaths in 2003 attributable to hypertension were 277,000. So that's why we care about high blood pressure. If you're diabetic and you have high blood pressure, that's 2 risk factors for heart disease. You can see over here that the risk goes way up if you're diabetic. So if you happen to have diabetes and you have high blood pressure, you want to bring it down. So the American Diabetes Association says bring it down. If you're diabetic in particular, that's the green bars, your risk is way higher if your blood pressure is up. So what are the issues here? Well, obesity and hypertension. A lot of Americans are overweight or obese. They're more likely to have hypertension. This aggravates everything. So again, obesity we got to fix. So let's look at when we try to fix things. We put people on diets, we give them medicines. How many are actually controlled? This is 1999 to 2000 data. I can tell you that it doesn't go up to 2010, but the latest data is 2006. It's the same. We're actually only controlling about 34% of our patients with high blood pressure, for the reasons I told you. Patients don't want to take the medicines. Patients can't afford the medicines. Patients don't want to lose weight. Patients can't lose weight. Whatever it is, in the United States, this is U.S. data, only about 34% of people with diagnosed hypertension are treated to a goal that is acceptable, that is below 140/90. I said acceptable, not optimal. Optimal is below 130/80. So what can we do? Well, you got to try to do better, and even small reductions in blood pressure are associated with large reductions in risk. So this is a graphic that I think is very telling. If you can just drop your blood pressure by 2 millimeters of mercury, sustained over time, you'll have a 7% reduction in the risk of heart disease and a 10% reduction in the risk of stroke. So just a small change, and if your doctor can get it down even a little bit over a lifetime, makes a big difference here. So that's why I'm telling you, a little bit matters, so try to do the best you can. And look here. If you have hypertension, we want to get it below here. But you know, most of my patients have multiple things. So if you have diabetes, you want it here. Who says so? The American Diabetes Association, not the cardiologist. 130/80 or below. Renal disease, 130/80. If you go to a nephrologist, they want to bring your blood pressure lower. And if you have a high-risk hypertension because you have multiple other issues, you want it 130/80, so not 140/90. I think you got the message. All right, let's talk about a couple of other real quick risk factors, and we'll be done. I'll be happy to take questions. But tobacco usage, I don't know if anybody still smokes. If you do, you should know what you're doing. So let's look at this, smoking and death. So again, if you have a genetic predisposition, that's presumably why you're here, and you smoke, you're asking for trouble. 33.5% of smoking-related deaths among Americans are cardiovascular related. So my patients that smoke all think they're going to get lung cancer. No, they're going to have heart disease, probably die of heart disease. Male smokers die an average of 13.2 years earlier than non-smokers. Female smokers 14 years earlier than non-smokers. Current cigarette smoking is a powerful independent predictor of sudden cardiac death, and cigarette smoking results in a 2 to 3-fold risk of dying from cardiovascular disease. So that's why we definitely, in this room, shouldn't be smoking. If you look at the prevalence, however, this is shocking to me. You know, I still have somebody in high school, and in high school, grades 9 through 12, in Caucasians, whites, about 25%, a little under that, 23% smoke. This is across the, maybe not in Cherry Hill or Haddonfield, but across the country, about 25% are smoking. And it's more in Caucasians than in blacks or Hispanics. Shocking, but true. This is U.S. Data from 2007. This is, again, on the American Heart Association website, plus they'll give you a copy, so if you want to look at it. That's the latest. Now, what if you quit smoking? What if you could talk your brother, your sister, your relative into stopping smoking? What would you be doing for them or for yourself? This is what you would do. Within 20 minutes, your blood pressure already comes down, your body temperature comes down, your pulse rate returns to normal. Within 24 hours, your risk of a heart attack starts to fall a little bit. It doesn't go to zero. It comes down a little bit. Within a year, your excess risk for coronary disease is cut in half. At 5 years, the stroke risk is reduced to someone that has never smoked. And in 15 years, your coronary disease risk is the same as someone who's never smoked. So you got to get started today to get this benefit. But that's, you know, again, this is data from the American Lung Association. All right, finally, obesity, and we'll talk about physical inactivity. These are things that really trouble me. I sit on the obesity task force for the state of New Jersey, and it's a problem, as you'll see. This is overweight among students grades 9 to 12, not in New Jersey, but in the country, whites, blacks, Hispanics. About 15, 16 to 20% of our children are overweight in the high schools. If you look at men and women, all comers, this is the purple here, this is us, 2003 to 06, that's the latest statistics. About a third of men in the United States are obese, not overweight. Obese means body mass index greater than 30. That means they're significantly overweight, obese. And about a third, a little more than a third of women are obese in the United States. So you see what's happened over time, from the 60s to the 70s, here to the 80s. So we're growing the wrong way. And because of that, we're having more diabetes and more everything, going crazy. All right, let's move on. Physical inactivity, and then we'll stop. Physical inactivity is important because we're not doing it. This is children again, but this is young children here, ages 6 to 19. And these are a little bit complicated, but these are children who attain sufficient moderately vigorous physical activity. MVPA stands for moderately vigorous physical activity. These are slides that go to the public health professionals, so that's why they're in language that you may not be familiar with. But moderately vigorous physical activity, ages 6 to 11, about half the kids actually get close. About half. That means half don't. But look, over age 11 here, we're down to about 10%. Why do you think that is? That's it, computer. Because these are the kids, this is the generation that no longer goes out to play ball. You know, when I was a kid, there was no computer. You went out and you played ball. They don't play ball anymore. They sit at home. Everything, the girls and the boys sit at home, and what do? They're on Facebook, they're on the internet. They have virtual conversations all over the world, but they're not running around. So we got to stop this. We got to stop this. Anyway, last couple of slides. This is just an old quote from 1972, but it's an oldie but a goodie. Dr. Gordon and Dr. Cannell were among the original investigators of the Framingham Heart Study, where a lot of these risk predictions came from, and they warned in 1972, my goodness, how many years ago? 38 years ago, that practitioners, means doctors, must come to regard the occurrence of stroke, coronary heart disease, congestive heart failure, and peripheral vascular disease as a medical failure rather than the starting point of medical treatment. What were they saying 38 years ago? We're waiting too long. You wait till you have the disease, then you say, I better do something. Now I'm going to go to my doctor. But what they were saying is, how about if you go first? You know what I mean? Like, try to prevent. So that's the theme tonight, is hopefully we can prevent or reverse or turn it around. So this is not scary stuff. What I'm talking about is I didn't talk about cutting anybody open. We're talking about trying to prevent disease through exercise, lifestyle, maybe some medications. That's all. Don't smoke. You know, walk around a little bit. Take the stairs instead of the elevator. You know, that kind of stuff. All right. So conclusions, cardiovascular disease is the leading killer of adults in the United States, men and women. I showed you that at the beginning. Risk factors are well defined. We know them. High blood pressure, diabetes, cigarette smoking, being overweight, being inactive. All those things are well known. And genetic risk factors. Okay, so we know that. But risk reduction strategies must be optimized. So if you know you're at risk, like in this room, let's do something about it. That's all. Try something. Try anything. Even if you lower your blood pressure a little bit, it's better. If you lower your weight a little bit, it's better. If you walk a half an hour, it's better than none. If you walk 15 minutes, better than none. You know, whatever you can do. So that's the thing. There's a little cartoon I like to end with. I don't know if you could read that, but there's a gentleman ordering from the menu in a restaurant here, and the waitress says, do you want that with or without a statin? And that's kind of the message. You know, if you're going to eat bad, then you better at least be taking the medicine, because you got to do something. All right, so thank you very much. I'll be happy to take any questions.